All right, good morning, everybody. We're going to go ahead and get started. I'm Kira Davis, Education Program Manager in Stanford Center for Clinical Research. And if you're here for the science series, you're in the right room. We had a little switch this morning, so sorry about the confusion. I would like to introduce my colleague, Susan Saba. So she helps me organize the science series as well as GCP workshops and any other education and training we're doing in SCCR. I also wanted to mention I recently sent out a flyer for our first GCP workshop, which is taking place next month, about a month from now, March 7th, from 9 to 11. And I sent out that flyer recently. If you haven't received it and are interested, the topic is preparing for an FDA audit. And we have an external speaker, Patty Casper, coming in to do that lecture. It is limited seating. We have I think about 15 people signed up right now and need another 10, so it's a total of 25. But again, if you're interested, please let me know. I'm happy to resend the flyer to you. And our next science series is going to be in April, and we are working on the details of that lecture now, so look out for that flyer in the coming weeks. And I will turn it over to Susan to introduce our speaker for today.
Hi, everyone. We are very pleased to have Dr. Anna Lembke here with us. She's the associate, sorry, do you hear me up there? Yep. Okay. She's the associate professor of psychiatry and behavioral sciences and medical director of addiction medicine and the chief of addiction medicine dual diagnostic clinic. She was the first in the medical community to point out alarm regarding the opioid overprescription and the opioid epidemic. And in 2016, she published her best-selling book, about the prescription drug epidemic, which was called Drug Dealer MD: How Doctors Were Duped, Patients Got Hooked, and Why It Is So Hard to Stop, which combines some case studies and public policies and cultural anthropology, neuroscience, and explores complex cultural, complex relationships between doctors and patients around prescribing controlled drugs, the science of addiction, and the barriers to successfully addressing those problems. And so I pass the torch to Dr. Lembke, and we are really honored to have you here and to educate us about the opioid epidemic. Thank you.
Thank you so much. Can everybody hear me okay? Yeah? Okay, great. So first of all, thank you for inviting me. I'm honored to be here to talk with you today. It's really a luxury for me to have 2 hours. I don't know how many of you are able to stay for the full 2 hours, but it seems like I'm increasingly being invited for shorter and shorter amounts of time, partially because I think our culture is just used to the 10-minute TED Talk. So I've flown across the country to give a 10-minute talk and then flown home again, which is really challenging. So I'm delighted to have some space today. And because of that, what I'd like to do, basically the talk today is divided into 3 parts. Number 1, kind of how did we get here? Number 2, where are we now? And number 3, how can we move forward? And what I'd like to do is pause after each of those segments and really open it up to any questions that you may have. And I welcome any and all questions. That's actually my favorite part of public speaking, is answering questions. Okay, so let's go ahead and get started. For the entirety of my career, I have never had any financial disclosures or conflicts of interest, but for the first time I do. I've been retained as an expert witness on the plaintiff's side for the multi-district opioid litigation against manufacturers and distributors. But I have not been paid for any of the material that you're hearing about today. This is basically based on my book. Okay, so in terms of thinking about this in a historical context, prior to 1980s, doctors were reluctant to prescribe opioids because they were afraid their patients would get addicted. And for good reason. This country had already seen 2 major opioid epidemics or 3 depending on how you count it, but the first starting in the Civil War when morphine was used in wounded soldiers, escalating to the early 1900s, an episode called narcomania, when morphine and heroin were actually sold over the counter next to Bayer aspirin. Then there was the Harrison Narcotic Act, which made that illegal. So there was a decrease in the problem until the 1970s when we had our Vietnam War veterans who had come back, became addicted overseas and came back. But nothing compares to the current epidemic we're facing today, and I'll talk a little bit about what's so different about the current problem. So what happened in the 1980s is that there was a paradigm shift inside of medicine because there was recognition that we were not doing enough to help patients in pain. The 1980s was also the advent of the hospice movement imported from Europe, which was heavily advocating for using opioids more liberally at the end of life as part of compassionate care. So what started as a very well-intentioned movement unfortunately gave way to the following. By the end of the 1990s, doctors were dispensing opioids like vending machines to pretty much anybody who came in and said, I have pain. And today we're facing the worst opioid epidemic in U.S. history. How many of you have seen this image before? Okay, so a couple of people. This was taken by the Ohio Police Department. These are individuals who were found in their minivan pulled over on the side of the road. The woman in the front is the grandmother of the child in the back. The driver is her friend. They are not deceased, but they are unconscious because of opioids. And I show this picture just to bring home the multi-generational trauma wrought by addiction and by the opioid epidemic. You'll note the watchful waiting of the child in the background. But I also like to emphasize that people who get addicted to opioids are people who drive minivans. They're people who remember to strap themselves in with their seatbelts. They're people like you and me. It's important to remember that this opioid epidemic is first and foremost an epidemic of overprescribing. Again, what began as a well-intentioned effort led to a quadrupling in the opioids prescribed for patients, which went in lockstep with the number of opioid-related deaths. This is no longer considered to be a coincidental correlation. This is really considered to be causative. As we began prescribing more opioids to our patients out of primarily good intentions, we essentially created today's opioid epidemic. We're now in the second wave of that epidemic, and I'll talk a little bit more about that. So who is prescribing all of these opioids? Well, certainly there are so-called pill mill doctors, doctors who are willfully exchanging prescriptions for cash. These kinds of doctors who have lost their moral compass have always existed and will always exist. But I think to conceptualize this epidemic as primarily driven by morally compromised pill mill doctors is to really misunderstand how this came into being. This epidemic is the result of prolific prescribing across all physician and prescriber groups. And I'll use the term doctor here very liberally to include RNs, anybody who's prescribing. So in other words, this is not driven by a small subset of morally compromised doctors. Although those doctors exist, pill mills exist, pill mills have been shut down. That's been one of the major interventions. The bottom line is that we're all prescribing too many opioids. This was an analysis that we published in JAMA, looking at which doctors are prescribing opioids. And what you'll see in the top is that by volume, family practice, internal medicine, and nurse practitioners are prescribing the most opioids. Why? Because there are more of those kinds of doctors than any other kinds of doctors. So simply by volume, that's where we're getting the most prescriptions. By specialty, it's pain management. That's the yellow bar in the middle. And that makes sense too, just like we would expect oncologists to prescribe more chemotherapy. But the bottom line of what we found in this analysis is that there wasn't a small subset of people accounting for the vast majority of prescriptions. Across the board, everybody's prescribing more opioids. Okay, so how did we get to this place of overprescribing? It's really fundamental to understand the role of the pharmaceutical industry, namely opioid manufacturers. Opioid distributors also played a role. These are the people who carry the opioids to various communities, but I'm really going to focus on opioid manufacturers like Purdue, Endo, Janssen, companies that you've heard of. We all know about direct-to-consumer and direct-to-doctor advertising. That's been going on for a long time, and it's highly effective. But I think to really understand how this epidemic came about, it's essential to realize that the pharmaceutical industry, Trojan horse style, infiltrated the medical community to convince doctors that prescribing opioids is evidence-based medicine, that there was actual science behind the use of opioids liberally, especially in the treatment of minor and chronic pain conditions. And they did this essentially by infiltrating things like continuing medical education, speakers bureaus. They infiltrated the Joint Commission, and in 2001, the Joint Commission made assessing and treating pain the quote-unquote fifth vital sign. They enlisted key opinion leaders, among them primarily academics working at places like Stanford, to go out into the community and promulgate the wonders of liberal opioid prescribing. They enriched these individuals' careers in many different ways. They also infiltrated, frankly, the FDA to make it easier to get opioids approved for various conditions. And in that process, they were able to perpetrate the following myths about opioid prescribing. I'm going to go through each of one of these and talk about what the myth is, and then I'm going to talk about what the evidence really shows today. So the first myth, opioids work for chronic pain. Opioids are great treatment for acute pain. There is no evidence to show benefit of opioids in the treatment of chronic pain, defined as pain every day for longer than 3 months. There are no placebo-controlled trials longer than 16 weeks showing benefit of opioids. And in fact, if you look at the, oh, I'm sorry, I was going to go through each of these. I'll go back to the literature. Okay, so that's the first one. The other thing is that now we know that patients who are on opioids daily long-term are at increased risk for lots of adverse health consequences, including increased pain, through a phenomenon called opioid-induced hyperalgesia. It changes the pain threshold so it's easier to experience pain. Myth number 2, that no dose is too high. This is the idea that if you have a patient who responds to opioids and they come back 3 months later and they say it's not working, just keep going up and up and up on the dose. There are many examples in opioid manufacturer literature urging doctors that there is no limit on the dose of opioids. I mean, that's how we got to where we are today with patients on these astronomically high doses of opioids. Myth number 3, that less than 1% will get addicted. So this was promulgated again in many different ways in the medical literature, that as long as you are a doctor prescribing opioids for a legitimate patient for pain, that somehow there's some sort of magic halo effect conferred and that patient can't get addicted. And we know that's not true, and I'll show you some of the more recent data on that. Myth number 4, this idea of pseudo-addiction and breakthrough pain. If you have a patient who's demonstrating all the signs and symptoms of addiction, they're not addicted, they're pseudo-addicted, they're in pain, go up on the dose. The other concept of breakthrough pain, which we really take for granted now, that was really invented by the pharmaceutical industry to describe the phenomenon of tolerance. When it stops working, patients have more pain. And of course, the pharmaceutical industry said, well, let's have long-acting opioids and short-acting opioids used in conjunction to help manage quote-unquote breakthrough pain. Myth number 5, that opioid dependence is benign and easily reversible. So I think this is a really important point. We've focused heavily on patients who have become addicted to opioids, but there is a large cohort of probably at least 10 million patients in this country who are physiologically dependent on high-dose opioids but do not meet diagnostic criteria for addiction. Neither do they self-identify as having addiction. They've always taken their medication as prescribed, but they're on dangerously high doses. What opioid manufacturers would have doctors believe in the 1990s and early aughts is, hey, dependence is normal. It's like insulin for diabetes, and it's easily reversible. You can just take patients down and off their dose by 10% per week. Now we know that's not true, that dependence has its own problems, and that many patients really struggle to get off of opioids, even without the manifestations of addiction. And then finally, this idea that screening patients reduces risk, which makes a lot of sense, right? That if you can just select the right patients, exclude those vulnerable to addiction, then there won't be any problems. There is no evidence that screening patients will actually lead to fewer opioid problems, and I'll talk about some of the recent literature on that. Okay, so what does the evidence really say about pain efficacy? First of all, again, want to emphasize multiple Cochrane reports showing there are no randomized clinical trials longer than 16 weeks showing benefits of opioids over placebo, and the literature showing support is highly biased using enriched enrollment funded by pharmaceutical companies and really constitutes very weak evidence. The SPACE trial was just published last year, really important for you guys to know about. This was a gold standard assessment of opioids versus non-opioid medication like Tylenol and ibuprofen in a population of opioid-naive chronic pain patients in a primary care setting. They divided them into two groups, gave one group opioids, the other these non-opioid alternatives, followed them out for a whole year. Now that's a robust study for the assessment of chronic pain. And what did they find? Opioids no better than Tylenol. Furthermore, patients who were on opioids ended up having a lot more adverse health consequences, not funded by a pharmaceutical company, did not exclude patients with mental health conditions, which is really important because the majority of chronic pain patients suffer from co-occurring mental health conditions. 2018, you might have seen this study by Busey et al. Published in JAMA, a meta-analysis, finding again no minimally important difference between opioids and placebo. What does the evidence really say about dosing and safety? Remember the second myth that no dose is too high? Well, really, what we now know is a wealth of accumulating evidence showing that the higher the dose and the longer the duration, the more adverse events. What do those adverse events include? Things like tolerance, needing more and more to get the same effect, dependence, being physiologically dependent on it such that you experience withdrawal if you cut back on the dose, hyperalgesia, opioid-induced increased pain, depression, cognitive dysfunction, constipation, hormonal imbalance, addiction, and death. This study by Dunn et al. Is the kind of study that the CDC guidelines was based on. You'll see here that they evaluated large numbers of patients and showed that patients who were getting more than 15 morphine milligram equivalents daily were at 3.7 increased risk of overdose. Those who were getting more than 100 milligram equivalents daily, almost 9 times risk of death due to opioids. And this was compared to people on lower doses. Hence the CDC guidelines recommending that if you do use opioids long term, you don't go above the 50 to 90 morphine milligram equivalents. What does the evidence really say about addiction risk in patients who are being treated with opioids for chronic pain? The evidence that's emerging now, it looks like the risk of opioid misuse, that is using your prescription in ways other than prescribed, is about 25%, so about a quarter of our patients. And developing a full-blown opioid addiction is about 12% of our opioid patients. I think these are actually underestimates because a lot of the way that they have defined opioid misuse, binging and hoarding, crushing and snorting, using it for energy, using it for mood, are things that I think could potentially qualify as having an addiction, maybe a milder form, in which case we're talking more like 35 to 40% of patients will develop an opioid use disorder in the course of being treated for a pain condition. This is a really important study by Edlund et al. Looking at if you take a population of pain patients and give them opioids, what's the chances that they're going to go on to develop an opioid use disorder? And found that though, compared to those not prescribed opioids, there was a 122 odds ratio of developing an opioid use disorder if you were getting more than 120 morphine milligram equivalents daily for more than 3 months. And what he found was a dose and duration effect. So the higher the dose and the longer you were on it, the more likely you were to develop an opioid use disorder. This is really, really important data, not the least because they also looked at other risk factors besides dose and duration. They looked at mental health diagnosis. They looked at prior alcohol use disorder. They looked at prior non-opioid use disorder. So they said, okay, we're talking about risky patients being patients who have a prior history of addiction or who have co-occurring mental health, which we know are risks for developing opioid use disorder. But the risk of developing an opioid use disorder pales in comparison to dose and duration. The higher the dose, the longer the patients are on them, the more likely they are to get addicted, 122 times those who are not exposed to opioids. Again, one of the biggest risk factors for becoming addicted to any substance is simple exposure to that substance, and this is living proof. So what does the evidence really say about dependence? Remember, dependence as distinct from addiction. Dependence is that physiologic phenomenon. Now, most people who are addicted to opioids are also dependent on opioids, and many people who are dependent are addicted, but you can be dependent without being addicted, and you can be addicted without being dependent. The bottom line is it's really easy to get patients onto opioids and really hard to get them off, even if they're not addicted. 1 in 7 opioid-naive patients who refills an opioid prescription will become a persistent opioid user 1 and 3 years later. And you guys, you know what I'm talking about. You've seen that in your patients who get a minor surgery, get put on opioids, and then just can't get off of them, and 3 years later are still on that opioid. We also know that many chronic opioid therapy patients will struggle to decrease their doses, even when doctors are educated, even when there's a plan in place. This is a study by Weimer et al. Showing that a hospital-wide clinic policy to implement high-dose legacy patients and get them down on their doses, and educated physicians to put a whole thing in place. In the post-intervention period, there were 71 or 63% of their subjects continued on high-dose opioids. In other words, they didn't get a lot of traction tapering their high-dose opioid patients down. And I'm talking patients who are on 500, 800, 1,200 morphine milligram equivalents daily, patients who clearly need to come down from their dangerous doses. There's evidence emerging now, though, that when we take those patients, those chronic opioid-dependent pain patients who are not addicted by DSM criteria, and we lower their dose, their pain actually gets better, right? So during the opioid withdrawal period, the pain is worse, but once they're down to a lower dose or off, their pain actually gets better. Why? Because of this opioid-induced hyperalgesia phenomenon. Okay, and finally, what does the evidence really say about patient screening? This idea that we can separate patients and get our high-risk ones over here and not give them opioids, and our lowest ones over there and give them boatloads of opioids. Well, this was going to be the solution to this problem using, for example, something called the opioid risk tool, which some of you may have heard of. It's a screening instrument. You ask things about past trauma. You ask things like co-occurring mental health disorders, and then you could tell based on the opioid risk tool who was going to develop a problematic opioid use later. Well, there was just a published study that came out that pre-screening is no better than chance. So basically, the opioid risk tool doesn't work. Self-report was no better than chance in predicting those who would have an opioid aberrant behavior. Really, really important. So it's not that that's not something worth striving for. Risk stratification, especially when it leads to a useful clinical tool, is really important. But the bottom line is we don't have one of those yet. So any patient to whom you prescribe an opioid is at potential risk for developing an opioid use disorder. All right, I'm going to stop there for a second and just see if there are any questions. Yes?
What kind of demographics are most affected by the opioid crisis?
Well, it's been shifting. In the 90s and early aughts, it was primarily patients who started with a prescription and then in some cases, many of them developed addiction, many of them died, some of them transitioned to illicit opioids. 2/3 of heroin users today began with a prescription opioid. That wasn't true, for example, in the 1970s, where 80% of heroin users started with heroin. And in many cases, that was middle-aged people of both genders. As time has gone on, and we're now in the second wave of the epidemic, and we have more and more people dying from illicit opioids, including fentanyl, we're seeing that age range go down, and the deaths are a growing number of young people who are dying from the opioid epidemic. In terms of geographic distribution, really it's affected every part of the country. Whites have been more precipitously affected than brown and black people, although the numbers are recently rising in those demographic groups. And most recently what we're seeing is that people in rural communities, especially economically disadvantaged and underemployed communities, have been most severely affected. Yes.
I know there are recommendations that everyone carry Narcan on them, right? And as a layperson responder, what would an episode in which applying Narcan, or like, what would that look like in someone that you just find unconscious?
Well, it's pretty easy, and you know, if you find someone obtunded or unconscious and you suspect that they may be unconscious due to opioids, the easiest intervention is the nasal spray. It's just one puff in one nostril or a second puff in the second nostril, and within 15 to 20 minutes, people will usually be rousable. So if you were carrying an naloxone injector or inhaler with you, there's also an injector, but it's not as user-friendly as the inhaler. You just do one puff in the nostril, and you call emergency services.
I'm sorry, the question was, like, someone's unconscious, how do you know, like, rather than CPR, that it might be an opioid issue?
Well, you don't know for sure. You can look for some soft signs like pinpoint pupils. That's a sign of opioid intoxication. But you know, just like in the emergency room, they have a series of things that they do when they have an unconscious patient because you just don't know clearly. First you do CPR, you establish that there's an airway, then you give dextrose in case it's related to sugar, you get an IV going, you give Narcan and see if they're arousable. If they are, then you knew it was opioids. If they're not, then it's something else. Yeah, so it's not so easy to tell. I mean, if you find needles around that individual and other paraphernalia, then it's a little bit, you know, those are indicators. You can't really harm somebody by giving them Narcan. It's not as if it's going to like interfere with another process. It's basically won't do anything unless they are opioid overdosed. Of course, they won't be happy when they wake up, but yeah.
Heart Association is talking about putting Narcan in every AED cabinet. Do you think that's a good idea?
Yeah, I think it's a good idea because why not have it everywhere, especially in a medical facility where, you know, where people are compromised for multiple reasons. I myself have never used Narcan on a patient, so I can't speak to any personal experience. But even if, you know, you saved one in 100, you know, I mean, that would be worth it. And it's not hard to use. It's not, you know, it's getting cheaper and cheaper. Yes. Yeah.
So, I don't know much about the opioid crisis, but I've seen a bunch of Vice documentaries about it. And
That's good.
I wonder, for the articles that you just presented, for the statistics, are they including heroin as an opioid, or are these purely doctor-prescribed legal opioid painkillers?
Yeah, so much of my work and most of my talk today is really focused on the problem of prescription opioids and the problem that comes from inside medicine. That's sort of my area of expertise and my contribution, and that's what I focus on. But certainly, you know, illicit opioids, heroin, illicit fentanyl are a huge and growing problem. In 2017, there was a 47% increase in fentanyl-related opioid deaths. Although, interestingly, cumulatively between 1999 and 2015, more people died from prescription opioids than heroin and illicit fentanyl combined. So although we've seen this spike of heroin in 2013 and fentanyl in 2015, we still have an ongoing prescription opioid-related problem. About a quarter of the deaths in 2017 were related specifically to prescription opioids. So although we're seeing a plateauing in those deaths, we haven't really seen a huge decrease in prescription-related deaths, as at the same time that we're seeing a spike in illicit opioid-related deaths, which is why overall deaths are going up. And I'll talk a little bit about some of the, yes, go ahead.
So then my next question for you would be, since in that previous photo that you showed with the grandparents,
Yeah.
I believe it was a heroin overdose?
You know what, I don't know what the opioid was. Yep, don't know.
So then do you think that the media has correctly portrayed how the opioid epidemic right now has kind of shaped itself? Because it seems like, right, since the prescription opioid overdosing has somewhat plateaued and the illicit use of opioids has kind of increased, do you think that the media portrayal of it is accurate?
Yeah, so the media has played a big role in the opioid epidemic, both in educating people and potentially sensationalizing it. Just speaking to this particular picture, there was actually an enormous amount of controversy that the Ohio Police Department released this picture. There's also, you've probably heard of or seen a video and pictures of a mother in a grocery store unconscious and her child trying to wake her up. And a lot of criticism that was unfair to the addict. But other people saying, if we don't show what's happening out there, then we're not going to get a movement on this epidemic. So the media interface with the opioid epidemic is interesting, and it's a whole topic unto itself. I think for the most part, the media has been helpful in getting the word out. I do worry, though, as you specifically address here, that the increased focus, appropriately so, on heroin and illicit fentanyl is going to divert from the ongoing problem of prescription opioid misuse and death, which is part of why I'm still eager to talk about this, I don't know how many years later, so that we don't get complacent about what is actually an ongoing problem. All right, which I'm going to talk a little bit about now in terms of where we are with the prescription opioid related piece. So overall, the good news is that opioid prescribing has gone down nationally by about 25% in this country, but we are still prescribing too many opioids. So we're prescribing 3 times as many opioids as we did in the 1990s, more than 4 times as many opioids as any European country, and more than 10 times as many opioids as Japan. And the reason that those are apt comparisons is that those are other rich countries with aging populations and comparable needs for analgesia. And this is just an article by a colleague of mine showing again that the U.S. outstrips other rich nations in opioid prescribing. We actually consume 80% of the world's hydrocodone, which is kind of just a remarkable statistic. I'm going to show you now data from the CDC from 2016 looking at variation in opioid prescribing across the country. Now we peaked in terms of opioid prescribing in 2012. So in 2012, we were prescribing, on average, 81 opioid prescriptions per 100 persons. So that's a lot of opioid prescriptions in terms of the population, right? The good news is that by 2016, we had come down to 66 opioid prescriptions per 100 persons. But here's a little cautionary tale. In 2016, Alabama was prescribing 121 opioid prescriptions per 100 persons. So the point is here, although nationally the numbers are improving, there's enormous geographic variation, and we have places in this country where we really haven't made much progress at all. California state average in 2016 was 45 opioid prescriptions per 100 persons, so well below the national average. As a state, we are doing well, but again, some counties with rates 7 times the national average. I'm going to show you this heat map. The darker red it is, the more opioid prescribing. You can see the southeastern United States is where we have still very high levels of opioid prescribing. California in pale yellow is doing relatively well, below the national average. But if you look at the same thing by county, what you'll see is a lot of county variation. So as you probably well know, the northern counties in California still have a very serious opioid overprescribing problem, and not surprisingly, also the higher number of opioid-related deaths in California. So a really important point, where there's more opioid prescribing, there are more opioid-related deaths due to prescription opioids and to illicit opioids. So that's kind of the take-home point. I'm not going to belabor this. This is Ohio, but you can just see the incredible variation within one state in terms of opioid prescribing. Here's a heat map representation again. You have this county in dark red with very high numbers, 119 opioid prescriptions per 100 persons. Okay, opioid misuse. Remember, opioid misuse is using it other than prescribed. It can take lots of forms. It's a stepping stone toward addiction, or maybe even is a marker of addiction. This is from the National Survey of Drug Use and Health. The take-home message here is that great big yellow circle represents the more than 11 million people who are misusing prescription opioids. That small circle is the million or so people who are using heroin. So when we're not looking at deaths and we're just looking at misuse, which we used to call abuse, misuse, or aberrant use, we have a much bigger prescription opioid misuse problem than we have a heroin problem. Where are people who are misusing prescription opioids getting their opioids? Well, 35% of them are getting them from a single prescriber. This large majority is getting them from a friend or a family member, many of whom got them from a prescriber. Less than 10% of people misusing prescription opioids are getting them from a drug dealer. Again, I think it's really important to emphasize that because per the question regarding the media, if you open the paper, listen to the news, you get more and more the impression that doctors are not in the mix and that people are using illicit opioids exclusively and getting them from drug dealers. That is happening, but prescription opioid misuse mediated through a prescription is still a huge problem. We published this in the New England Journal last year, talking about our other prescription drug problem, the hidden epidemic of benzodiazepines. There's been a 7-fold increase in overdoses between 1999 and 2015 involving a benzodiazepine. Many of those deaths had a benzodiazepine plus an opioid. When you combine those two, you have a 4-fold risk of accidental death. But some of those involve just a benzodiazepine, which can also kill. Okay, and just to bring it home, if I haven't yet convinced you that opioid overprescribing is still a very serious medical problem in our community, I want to tell you about a case, September 2017. This is a young man, 28-year-old man, diagnosed with fibromyalgia, being treated by a primary care doctor in the Kaiser system. My colleague, who was asked to look into this case, called me for a curbside. This is by her report, was a very lovely and competent young primary care doctor who inherited this patient from a doctor who retired. So this man with chronic pain from the tips of his eyelashes to the tips of his toes was on the following medication in September 2017, so maybe a year and a half ago now. 40 milligrams of Opana, an opioid, twice a day, 30 milligrams of Dilaudid, an opioid, once a day, 60 milligrams of oxycodone, an opioid, 20 milligrams of Valium, a benzodiazepine, 65 milligrams of phenobarbital, a barbiturate, 30 milligrams of dimazepine, a Restoril, a benzodiazepine, and 8 milligrams of Xanax once a day, all being prescribed by a single, reputable, well-intentioned prescriber. And these are the cases that were commonplace in the 90s and early aughts. We're seeing these less often now, but they're still pretty common. This individual is on the equivalent of 470 milligrams of morphine daily. Just to put that in perspective, the average heroin user uses about 100 morphine milligram equivalents daily. And of course, he's at imminent risk for death due to the combination of opioids and benzodiazepines. We are now in the second wave of this epidemic, as I alluded to earlier, with the spike in deaths due to opioids, primarily attributable to fentanyl and illicit fentanyl and heroin. But just again, note this. This is prescription opioids. It's plateaued, maybe gone down a little, but we still have a serious problem. And again, cumulative deaths still greater than illicit fentanyl and heroin combined. I will also add that, again, a major gateway to illicit opioid use is starting with a prescription. Okay, any questions about that? Yes?
Why do you think the U.S. has outprescribed all other countries?
Great, so that's a great question. That's what I'm going to talk about now. Anything else? Yes? Yeah. So, this was the practice of medicine in the 1990s and early aughts. This was good medicine. And interestingly, in the 90s and early aughts, if you were white and wealthy and had good health insurance, you were more likely to end up on this regimen than if you didn't have those criteria, because this was gold standard medical care. Now that we are seeing a shift, thankfully, and the recognition that that is insane to prescribe in that way, what we're seeing is, and I'll talk a little bit about this, is that people who are wealthy and have good medical care are getting off of those medicines, but nobody else is. So people who are poor and of color and have poor medical care or have, Medicaid are still being prescribed like that. And I'm going to talk now about why I think this happened. Essentially, to me, that case is sort of the quintessential example of this problem, because in 2017, a doctor could really no longer say, "Hey, I didn't know," or "That's what pharma taught me." Like by 2017, you couldn't open a paper or listen to the radio or go on your computer without seeing that we are in an opioid epidemic. So to me, this opioid epidemic is really the canary in the coal mine for a faltering healthcare system, that in fact opioids became the solution not to patients' problems but to doctors' problems. So what I'd like to do next is spend a little bit of time talking about what I mean by that. And I think in order to do that, we first have to understand what motivates the compassionate doctor, because again, this opioid epidemic is driven primarily by people like me, people who went into medicine to help others who thought they were doing good. It's not driven primarily by pill mill doctors. So what happened? First of all, to understand that, you have to understand what motivates the compassionate doctor. People who go into medicine and the compassionate doctor, and again, I use the term doctor loosely to refer to anybody who's interfacing with these patients in the healthcare system. Basically, we tend to be pleasers, people who know how to navigate the complex maze of the school system to get to the top of our class or to get into medical school or nursing school or what have you. We're kind of natural codependents and natural helpers. But we're also people who are responding to a higher calling, right? We choose medicine because we want to save lives and alleviate suffering. We don't go to law school or to business school, although those people may also want to save lives and alleviate suffering. But we more specifically are interested in that, which I think affects the interaction. As we go through our medical training, we're very socialized to empathize with our patients, to believe their story, to walk in their shoes. We really receive almost no education on what to do when our patients may be manipulating us or may be getting addicted. And that's true even in psychiatry. And then finally, I would say that most doctors are motivated by mutually affectionate relationships. That is to say, that moment when they can realize their identity as a healer and the patient feels that they've been genuinely helped. I know that's what keeps me going in the morning, even with all the pharmacy phone calls and prior authorizations and quality of life surveys and you name it, disability forms. I look forward to that moment when I'm going to see a patient and really have that human connection. The problem is, if I now have a patient who may be misusing an opioid I'm prescribing, very hard for me to know how to engage in a discussion about that without threatening this mutually affectionate relationship. All right, now let's talk about what motivates the drug-seeking patient. People who are becoming addicted or who have addiction lie, cheat, and steal to get their drug. Those are symptoms of the disease of addiction. For me, it was really helpful to understand the last 50 years of the neuroscience about what happens in the brain when people get addicted. And I've condensed it in a way that I'm going to relay it to you in 3 minutes, in a way that's understandable for me. Basically, seeking out pleasure and avoiding pain is natural and normal, and it's basic to our survival. And we have a region in our brain called the reward pathway, which is fundamental to this kind of seeking out pleasure phenomenon. But one of the interesting findings in neuroscience in the last 50 years is that the place in the brain where we process pleasure is co-located with the place in the brain where we process pain. So pain and pleasure are processed in the same areas in the brain. How do they work? What's the interrelationship? Basically, they work like a balance. So imagine that there's a tiny little balance inside your brain, and when it gets tipped one way, you experience pleasure, and when it gets tipped the other way, you experience pain. The overriding rule governing this balance is that it wants to remain level. It doesn't want to stay very long on the pleasure side or the pain side. And you can certainly imagine from an evolutionary perspective why that would be a good thing, right? If I'm sitting around sipping on nectar and a little bit of nectar keeps me that way for 4 days, I'm not going to notice the lion that's circling my campsite, right? Likewise, in an environment of scarcity, I have to be really motivated to seek out that watering hole, to make sure that I'm prepared for winter. So it's natural that I wouldn't want to stay in a pleasure state very long. It's also natural I wouldn't want to stay in a pain state very long, right? Excruciating pain. Hopefully my body will somehow habituate to that, and I'll restore a level balance. Okay. So I really like chocolate. So when I eat a piece of chocolate, that goes on the pleasure side of my balance, and I get a tiny little tip to the pleasure side. What's happening in my brain? I'm releasing dopamine. This is a very simplified version if you haven't gathered that so far. I'm releasing dopamine, which is the pleasure neurotransmitter. But I don't get to stay in a chocolate pleasure state for very long. Pretty soon what happens is a little gremlin, which represents neuroadaptation, hops on the pain side of my balance to bring me level again. What do I mean by neuroadaptation? That's the process by which the brain recalibrates in response to any pleasurable stimulus. It's amazing how quickly the brain can do this. It downregulates its own dopamine. It downregulates its own dopamine receptor. But here's the thing about the gremlins. They don't get off as soon as I've restored level balance, or what's commonly called homeostasis. The gremlins like it on the balance, and they stay on there until I'm tipped over an equal amount to the side of pain. And that's that moment of wanting a second piece of chocolate, right? If I just wait long enough, the gremlin hops off and I've restored a level balance. Yay, and that's how it works, right? It's a very efficient, very good system. Here's what happens when you consume an addictive drug. The fundamental difference between something that is addictive and something that is not is how much dopamine it releases in your reward pathway and how quickly it releases that dopamine. So I go to the doctor and I'm in pain, which means I'm a little bit tipped to the pain side because I've got pain, right? I don't even have a level balance. My doctor gives me some Vicodin, and what happens? That goes on the pleasure side. But I don't get a little tip. I get a great big tip because Vicodin is a powerful mediator in this reward pathway. I get a surge of dopamine. Woohoo! It relieves my pain, and it also makes me feel really good, okay? Now, there is a drug of choice phenomenon. It's not true for everybody. Not everybody responds well to opioids, but most people have a very positive response to it. But now with this big tip to the side of pleasure, I need a great big Arnold Schwarzenegger gremlin to bring me level again. So he hops on my pain side, brings me level, oh, okay, boom, down the other side. What is that? That is opioid withdrawal. It is very painful, nausea, vomiting, diarrhea, achy body pain all over. If I wait long enough, right, he hops off and I restore my level balance back to my chronic pain condition. I don't get a level balance. That's a bummer, right? Now imagine that I am taking Vicodin for days to weeks to months to years. Now I'm at war with my gremlins, right? I've got enough gremlins on the pain side of my balance to fill this entire room. And we're doing this, right? We're doing this. Then let's say I can't get any more opioids, or I've decided the opioids are somehow destroying my life and I want to stop. Goes off this side, I'm here, I smash down to the pain side, and this is the fundamental thing, I think, to understand addictive behaviors. I don't get to be not here I have to be in this state for a very long time. So this is not relieved after the 2 weeks of acute opioid withdrawal. I am, in fact, walking around in pain for days to weeks to months to years, right? Which is why people who have the disease of addiction will relapse even after a sustained period of abstinence because they're not walking around with a level balance feeling, good. They're in a state of pain, in a state of craving. If I'm like this and I now eat a piece of chocolate, what happens? Do I get pleasure from that chocolate? No. So you see, I have a recalibrated joy set point or a recalibrated hedonic set point. I now need much more dopamine in order to experience any kind of pleasure at all. And when I'm not using, I'm walking around in psychological pain, and it can last a very, very long time. We believe that with enough plasticity in many individuals, those gremlins will eventually hop off and homeostasis will be restored, and I will be able to participate in life as I did before. But we also believe that for some people, the balance gets broken and the gremlins never hop off and they're stuck here in this state of dysphoria, irritability, insomnia, anxiety. And that's where medications come in. Medications specifically to treat opioid addiction, like methadone maintenance, they go here, or buprenorphine, you might have heard of Suboxone, right? It goes here. It doesn't get these patients high, it just restores a level balance so they can participate meaningfully in their lives again. Okay. What I want to talk about next, so in other words, when a patient is manipulating their doctor to get a certain type of drug, we have traditionally called that malingering, and sometimes those patients just get fired from our practice. But I think that's not accurate. I think if we really conceptualize it as the disease of addiction and we appreciate the way in which the brain has been changed and the physiologic motivation of the drug-seeking behavior, I think we can restore our compassion for this problem. Any questions about that? Okay. What I want to talk about next is some of the manipulative techniques that patients actually use to try to convince their doctors to give them a certain type of prescription. These are somewhat lighthearted. They're not meant to denigrate these patients, but rather to reflect on, in a memorable way, what patients are actually doing out there to get prescriptions. So the first technique is the sedator. This is the filibuster technique. This is where patients wait to the last 30 seconds of the appointment to ask for a refill because they know that it'll take 30 seconds to say yes and 30 minutes to say no. This is the sycophant. These are the patients who flatter their doctor, telling them how much better they are than other doctors. By the way, this is not necessarily conscious. These behaviors can happen unconsciously. This is the exhibitionist, patients who will demonstrate their pain. They'll cry. They'll write on the ground. I've frequently had patients undress in my office when I've been in the pain clinic. Dynamic duo. These are patients who often come in with a significant other, often a mother. The mother is crying, the patient is writhing, very hard to say no, 2 against 1. The city mouse and the country mouse. So these are people who go to the extremes of the savvy spectrum. The city mouse will go into the emergency room and say, I'm allergic to all pain medicine except for IV dilaudid push with a Benadryl chaser. And the country mouse will say, oh, doctor, you know, I have a friend, she's on Oxy or Oxy, and then because I'm a natural codependent, I'll say, oh, OxyContin, that's it, doctor, and I'll write the prescription without realizing that I'm the third doctor that day that patient has gotten the same prescription for. The loser, these are patients who lose their prescriptions. Water tends to be a common theme here. They'll say it fell in the toilet, it went through the rinse cycle, fell in the bottom of my fishing boat. The weekender, these are patients who call in the evenings or on the weekends when they know a harried resident is happy to refill a prescription rather than have to spend time figuring out whether or not it's warranted. The twin, these are other healthcare providers. My personal Achilles heel, these are doctors and nurses. We went to the same schools, we know the same people. I never would imagine this person is manipulating me, only to find out later I was duped. The doctor shopper, you've heard this term. This is doctors who go around to multiple prescribers to get the same or a similar prescription. I've also seen the inverse of this, where patients will actually pretend to be different people and go around to different emergency rooms and have surgeries or procedures under different identities in order to get prescriptions. The bully, this is really the time-tested one. These are the patients who threaten to sue us, who threaten to call patient relations. I just got an email yesterday from patient relations about a patient of mine who's unhappy because I want to taper his benzodiazepine. Really, really hard for doctors to tolerate that kind of discontent among their patients, especially when it goes to like a higher level legal or patient relations in the hospital. Okay, so we've talked a little bit about what drives the compassionate doctor. We've talked about what drives the drug-seeking patient, namely this changed physiology. But the doctor and the patient are not working in a vacuum, right? They're working in a very large healthcare system, which is becoming increasingly complex. So what I'd like to suggest to you now that there are at least 3 invisible forces, I will talk about 3 invisible forces, that are actually incentivizing and driving overprescribing in this context. And the first is the Toyotization of medicine. In the last 30 years, there has been a massive shift in healthcare delivery. Physicians have migrated from physician-owned practice into large integrated healthcare centers. Today, more than 70% of physicians in this country work as salaried employees. This is an enormous shift. What it means is that we now practice protocolized medicine, and we do it en masse. So when these protocols come down the pike, there's a major overhaul. The Joint Commission comes in. They say jump, we say how high, and all of a sudden we're all practicing in that way. That can be good when the protocol is good and bad when the protocol is bad, like it was for pain as a fifth vital sign in the early aughts. But in general, what the toyotization of medicine has engendered is something I call the P paradigm. Enormous pressures on doctors to palliate pain, prescribe pills, and perform procedures because that is what is reimbursable, to protect privacy, even when it harms the patient, and finally to please patients. Essentially, we have become waiters, and our patients have become customers. I just give them Chinese menu item number 5, and I write the prescription. A couple of years ago, my then 11-year-old son decided to Google my name on the internet, and he said, "Mom, is this you?" He sounded distressed. I went over and I looked at this, and this was a doctor rating site, and down there, Corey, who I don't know, I don't remember, gave me 1 out of 4 stars and had this to say about me, which is why my son was distressed. She provides the kind of care that will make you wish you had never sought help in the first place. Wrong diagnosis, wrong medication. In some cases, this can be terrible. Seek help from someone else. And I was naturally mortified. If my 11-year-old son found this on the internet, who else had seen this? My colleagues, my friends. I've been all over the country in the past 2 years urging doctors to prescribe opioids and benzodiazepines more judiciously. And they invariably come up to me and say, "Doctor, we'll prescribe fewer opioids when you can promise us that our patients will still give us good scores on patient rating satisfaction surveys." In a lot of practices across the country, if a doctor doesn't get good scores, that individual can have a cut in their salary. It will directly affect their professional advancement, and it's certainly a source of public shame. Now, there is, in fact, no evidence to support the use of patient rating satisfaction surveys to lead to good care. In fact, this data point in the Archives of Internal Medicine shows that patients who rate their doctors higher are more likely to use inpatient services, take more prescription drugs, and are more likely to die even when controlling for comorbidity. So this is not, in fact, evidence-based medicine to use patient rating satisfaction surveys. Patient rating satisfaction is probably good for things like how was the parking and how was the wait time, and not a good way to get to good medical care, especially when you're dealing with complex populations with mental health problems and addiction in a chronic care model. Now, the good news for me is that my son did come out of the room a few minutes later, and he said, don't worry, Mom, I just gave you 4 out of 4 stars. Twice. So I was happy about that. All right. The second invisible force driving over prescribing is the medicalization of poverty. So another huge shift in the past 30 years has been increasing demands on doctors to care not just for their patients' biomedical problems, but also their patients' psychosocial and spiritual problems, without giving providers the tools to actually address those problems. So instead, healthcare providers have been forced to medicalize problems that are not in fact medical, and then, of course, prescribe a pill, because that's what we do. What that means is that we have patients coming in with multi-generational trauma, with unemployment, with homelessness. These are really serious problems that we essentially don't have much help for. So instead, what do? We glom onto their pain condition and we prescribe them an opioid. And of course, in the short term, they actually do feel better, but in the long term, they're being harmed, and we're not addressing the underlying cause. And this kind of medicine is especially severe when we're dealing with the poor and the vulnerable in this country. The poor are, in fact, treated differently when it comes to opioid prescribing. People receiving Medicaid are prescribed opioid painkillers at twice the rate of non-Medicaid patients and die from prescription overdoses at 6 times the rate of non-Medicaid patients. Although I showed you that nationally opioid prescribing is going down, among Medicaid patients, it has not gone down appreciably since the peak in 2012. Medicaid poor patients are basically being prescribed opioids as a kind of a blanket substitute for very serious psychosocial problems. I showed you this heat map before looking at opioid prescribing. If you take this heat map and you superimpose it on a map of U.S. unemployment by county, you'll see remarkable similarity. Where people are in economic and social distress, we have more opioid prescribing. The demand for opioids is not just something that doctors are creating out of desperation to help patients and do the one thing that they can do. It's also driven in part by patients themselves who are increasingly adopting the sick role as a way to pay the bills. Social Security disability insurance in 1957 in this country, we had 150,000 people receiving SSDI, and the primary reasons were cancer and cardiac disease. Today, there are more than 8 million people receiving SSDI primarily for pain and chronic pain and mental health conditions. And that's true for the other federally funded disabilities, SSI, and veterans compensation. Part of what is happening here is, in fact, that we have no social safety net, that medicine has become the social safety net, and that patients are going on to disability, consciously or otherwise, as a way to get a monthly income. It's much less stigmatized than being, quote unquote, unemployed. But in many instances, in order to validate that sick role, they have to take certain types of pills. They have to consume health care, and that can be a dangerous proposition. Karl Marx said religion is the opium of the masses, and I think we are at a point in history when opium has in fact become the religion of the masses. I'm sure you have heard of the deaths of despair work. This is a phrase coined by Ann Case and Angus Deaton, Princeton economists, who noted that for the first time in many generations, white middle-class Americans have a shortened lifespan due to drug overdose, liver cirrhosis, primarily alcohol-related liver cirrhosis, and suicide. So to me, this is fascinating. For most of human history, we have lived to about 30 years, about 3 decades, until 150 years ago, when because of public health advancements, there was an exponential growth in our lifetime longevity. Now, average lifespan is 80, 90 years old in developed countries. We have more centenarians, people living over 100 than ever before in the history of the recorded world. And even in emerging economies, people are living much, much longer. Yet here we see in the US of A that people are now, especially non-Hispanic, white, middle-aged Americans are dying earlier because of these sorts of overconsumption diseases related to drugs, alcohol, and of course, depression and suicide. I think the third invisible force driving overprescribing is cultural narratives around pain. So we now believe that pain experienced in any form is dangerous, that patients who experience psychological pain are ripe for post-traumatic stress disorder, that patients who have a physical pain syndrome that's not immediately alleviated can go on to develop a centralizing pain syndrome, something like fibromyalgia. That the experience of pain leaves a kind of psychic scar, setting up people for pain in the future. And as such, it has become the mandate of healthcare providers to eliminate all pain immediately, lest they are demonstrating lack of compassion for their patients in the here and now, and also exposing their patients to a lifetime of chronic pain. Whatever you may think of post-traumatic stress disorder or centralizing pain syndrome or this concept, it's a very modern concept. So prior to 150 years ago, doctors actually believed that pain was salutary. They believed that it boosted the immune response, that it boosted the cardiovascular system. In fact, in the mid-1800s, when general anesthesia was just being invented, the prominent surgeons in this country didn't want to adopt it because they felt that their patients were better off experiencing perioperative pain in order to heal faster. Obviously, we don't feel that way anymore, and I think that has contributed to opioid overprescribing. Other narratives that are prevalent now in medicine that contribute to it are the idea that people are fragile, that the body cannot heal itself, although one of the most remarkable aspects of the human body is its ability to heal given time. That doctors, especially aided by technology, have superhuman abilities to heal, and that victimhood is a right to be compensated. Any questions about that before I move on to the last part of my talk today? Yes.
2 years ago, my son had an open heart surgery, and the doctor prescribed paraventral blocker
Uh-huh.
in order to help with anesthesia. But also the rationale behind that was to kind of help to control the amount of painkillers that he could receive
Right.
after the surgery.
Right.
So in the end, he surged and caused a little bit of In the end, he did not use any opioids.
Wow.
He was able to control just with any other, I think it was Tylenol.
Right, right.
That it was not opioid.
Mhm.
And what do you think about using part of it, the drug blocker, to avoid giving so many opioids after?
Right. Well, thank you, first of all, for sharing your story. And it sounds like your son had a successful surgery and is doing well. That's wonderful. So this is a very big movement now, perioperatively, trying to find ways to minimize the use of opioids during and after surgery in order to prevent that exposure that we know can lead to persistent opioid use, that can lead to addictive use. So it's a very exciting movement, a lot of different types of interventions to, again, minimize exposure to opioids. It sounds like in your son's case, he may never have developed an opioid problem, but using the alternatives was successful. So yeah, lidocaine infusions, ketamine is common now, multimodal analgesia. It's a burgeoning and important area of exploration because we do know that surgery is a gateway to persistent opioid use. Something like 1 in 8 to 1 in 10 people who receive even minor surgeries can go on to develop persistent opioid use and opioid use disorder. So it's an important advance. Okay, what I'd like to do now is talk about the psychodynamics of the interaction between drug-seeking patients and compassionate doctors when this problem arises. Basically, what happens when a well-intentioned doctor encounters a drug-seeking patient? Naturally, that doctor feels kind of caught between a prescription and a hard place, and as such experiences anxiety, as we all would when we feel that we're in an uncomfortable situation. And naturally, then what does the doctor do? To manage that anxiety, she enlists her primitive defense mechanisms. Now, as you all will recall, defense mechanisms is a Freudian concept. The idea is that we enlist these unconscious strategies, so we don't do it knowingly, it's beyond the level of awareness, in order to manage uncomfortable emotions. And so, for example, if I'm feeling anxiety, I may not even be aware that I'm feeling anxious, but in order to alleviate my anxiety, I will engage in some kind of primitive defense mechanism and my anxiety will go down. So these work, right? And we all do them to varying degrees. And in the short-term crisis situation, they're quite adaptive. What is not good is when it's your only defense and it's used long-term for every situation. So the most common primitive defense mechanism that doctors use when encountering a drug-seeking patient is actual denial. Just pretending like it's not happening. Like, I'm a good doctor and the patient's fine and there's not a problem here. I'll just write the prescription. Another primitive defense mechanism is projection. That's where I take an uncomfortable emotion that I don't want to acknowledge and I project it onto another person. So for example, I may feel rage toward this drug-seeking patient, but instead of owning my rage, I'll project my rage onto the patient and say that person, that person has a personality disorder, or that person's a jerk. Or I'll talk about that person, behind their back with the nurses. So some kind of denigrating by projecting my emotion onto the patient. Another common defense mechanism is splitting our patients between our good patients and our bad patients. So our good patients are the ones that take a few minutes. I know what they have. I can fix it. They bring me chocolates at Christmas time. It's all good, right? My bad patients, they're complicated. They take a lot of time. I don't know what to do for them. They make me feel incompetent. This is, again, it's not a good thing, but it's something that we kind of naturally do, mostly unconsciously, vis-a-vis our patients. And then passive aggression, the most common manifestation of passive aggression is just plain old procrastination. Like the patient calls me, but I don't call them back. I put it off. I'm rounding in the hospital. I should take more time with this complicated patient. Instead, I just like, oh God, I don't want to go in there, spend 30 seconds and get out as fast as I can. I should see the patient in a week. Instead, I say come back in, 4 months. This kind of putting it off. So what happens when the compassionate doctor and the drug-seeking patient actually get a room? This is a dramatic reenactment.
Well, this is great. We talked about your diabetes, you talked about your hypertension. I put in a referral to the nutritionist, and you're doing great. So I will see you next time. Okay?
You are so good, doctor. Thank you so much. I just love working with you. You're so much better than my old doctor. You take time to explain everything to me. I really appreciate that. I filled out one one of those surveys out at the front desk. They give you the patient evaluation thing, you know. I just glowed about you. I just love having you for my doctor. Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up. You know, I think it's probably because of all the extra cooking and cleaning I had to do while the kids were in town.
Okay. Yeah, I'm not sure that's a good idea. I think I just gave you an early refill last month. I mean, I'm not sure. I'd have to check the computer.
No, I don't think so. I don't mean to bother you. I'm really sorry. I know you're super busy. It's just that my pain has been so bad, you know.
Yeah, and I hear you about the pain. It's just that, you know, you're at really high doses, and we've gone up a lot on the doses, and I'm starting to think, you know, maybe I need to refer you to a pain specialist. Maybe it's kind of, you know, more than I can treat at this point.
Nobody understands. Nobody understands my pain. My husband doesn't understand. My kids don't understand. I thought you were the one person who understood. I have one person to care. I wish you could spend just one day in my skin, 1 hour in my skin. You would understand how unbearable this pain is. Now I see you don't even get it. You just kind of get rid of me, push me off on some other doctor, and abandon me.
Oh, okay, I'm not trying to, I'm not trying to abandon you. I care about you. I care about your pain. Okay, I will write you an early refill this time, okay? But this is it, okay? This is the last time. Please just take it as prescribed.
I will, doctor, I will. I promise I will.
I'm not going to do any more early refills, right? This is it.
I understand. It's just that with my family in town and the holidays and all the stress and that's all it was.
Okay.
I'm sorry I broke down like that. I know you care about me. I know you really do. You've always been great.
Okay.
So, I just did those things because I was scared.
Yeah, no, that's okay. No, that's okay. I understand. Okay, so really nice to see you, and I'll see you next time, okay?
Thank you.
Yeah,
Thanks
yeah.
so much.
You're welcome. All right, take care.
Thanks.
All right, bye-bye. Okay, so it's always funny to show this video to different audiences, because when I show this to doctors, they absolutely roar with laughter because there's kind of a recognition of, you know, the kind of care that we've all engaged in that we're not proud of. You know, this patient is complicated. There were lots of warning signs that something was amiss, but instead the default was just to sort of be in denial about it and continue the prescription. But that eye roll at the end also bespeaks, you know, this kind of projection and splitting. This is somebody who the doctor doesn't care for, but also speaks to the kind of inauthenticity that leads to burnout that doctors experience when they're practicing in a way that's not consistent with their values and that they don't believe that they're in fact providing good care. So this was an example of a kerfuffle that perpetuates the problem. There were lots of, again, opportunities for this doctor to intervene in different ways. But instead, she enlisted her various primitive defense mechanisms to pretend like nothing was happening. But what if the doctor actually checked the prescription drug monitoring database? Does everybody here know what that database is? Okay, so this is a database that's actually been around for a long time. It comes from the DEA. It's a database that gives us the ability to look at all the prescriptions for any controlled drug, i.e. addictive drug, the patient has received in the last 12 months in a given state. And I started checking the prescription drug monitoring database in the early aughts, and I was shocked to find out what I did. You know, I had sweet little old ladies who were abusing, you know, Xanax that I had no idea, and I had been writing the Xanax prescription for I don't know how long. It's been really, really revelatory, and now it's actually become law in many states, including in the state of California, that we now have to check the prescription drug monitoring database before writing a prescription for an opioid. And this is really good because
the data show that when doctors check this database, they don't prescribe when they shouldn't. And in some instances, when they were suspecting that the patient might be misusing or addicted, then they will prescribe when they see that there's not a problem. And there's a literature showing a lot of implicit bias having to do with race, discriminating against people of color, thinking that they're misusing when they're not. So there are all kinds of reasons why having these objective data are really important and useful. But, you know, fascinating, voluntarily doctors wouldn't check the database. So even with all of the important information you could get to elucidate doctor shopping or combining opioids and benzos, only about 35% of doctors were checking this database until these laws were enacted and it became mandatory. And some of that is because, you know, everybody's harried. There are a lot of things to check, a lot of labs. It's complicated. You don't have time. But it's so, so important to delivering, you know, quality and safe prescribing. So what happens, though, if the doctor does check the database and finds out, oh, my goodness, you know, this patient is different than what I thought. This patient is you know, misusing the pills I'm prescribing. Well, the doctor typically will experience a narcissistic injury. I always like to point out that you don't have to be a pathological narcissist to experience a narcissistic injury. There's something called healthy narcissism. This was a concept put forward by Kohut, a famous psychoanalyst in the last century. Basically, anything that we invest our creativity and energy into is something that makes us vulnerable for a narcissistic injury. So whether that's being a good doctor or being a good parent or being a good researcher, if somebody does something or says something that makes us feel less than, we often experience a narcissistic injury. It's often unconscious. It often hits us immediately outside of awareness. Just to give an example, for years, this was years ago, had been giving a talk as part of a series on mental health. I'd been giving a talk on bipolar disorder, organized by one of my colleagues in the psychiatry department. And one year, without speaking to me or you know, explaining why, he didn't invite me back to give the talk. And I didn't really think about it, or I didn't think I was thinking about it one way or another. But at a faculty meeting, he raised some point or some issue, and I just ripped him to shreds. I was like, and it was something I basically agreed with. I totally disagree with that, and I went on and on. Anyway, I left the faculty meeting, and I was like, that was so weird. Why was I so angry at him? And I only realized later that, oh, you know, I was narcissistically injured, and I took it out on him, because the most common reaction to a narcissistic injury is something called narcissistic rage and retaliation. But it's amazing how unconscious it can be. It can be something as simple as you're walking down the hall, you pass somebody, you say hello, they don't say hello back, right to the gut, right? Could be they were lost in their head and didn't even see you. It doesn't matter. You say hello, they don't say anything, you feel it's a kind of a shame that engulfs you. So let's see what happens in a kind of Groundhog Day redo when this patient checks the prescription drug monitoring database.
I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up.
Okay, I'm not too comfortable with that, but I'll tell you what, I just got access to a brand new database that allows me to look at all the prescriptions that you've received in the last 12 months in the state of California. So let me just look your name up on that, and you know, that will kind of help me be able to make a decision about whether or not, you know, it makes sense to do more pain meds, okay? So just give me 1 second.
Is that something that you can do after I'm gone? I really kind of need to get back to
No, let's take the time. I think it's worth it to take the time now. Oh, wow. Wow, I'm surprised. It looks like you've been to see a couple of other doctors to get more opioids, and there's some benzodiazepines, clonazepam, and
yeah, I can explain that. I have a tooth abscess. I went to see my dentist this week. So
okay. This Dr. Smith, I mean, who's the Dr. Smith on
Dr.
there?
Smith is my OB-GYN. You know, I've been going to her for years, and it was just time for my pap smear. So I just had, you know, I had several people I had to see this week, but of course you're the person I count on.
Okay. And who's this Dr. Williams here? And there's a Dr. Jones. I mean, seems like a lot of meds going on there, the same ones I'm prescribing.
Well, they have a medical condition condition that involves pain. So this pain medicine is obviously something that I need in order to manage the condition. I don't know why I feel like I have to defend myself about this.
Okay, well, I'm sorry, but I'm not going to be able to prescribe opioids anymore for you. I mean, you're obviously addicted, and I'm not going to be able to, I don't think I can actually treat you anymore. I'm going to have to ask you to leave.
Addicted? It's not like a drug addiction or an alcoholic or something. This is a medical condition. I'm getting pain medication for a medical condition. I thought I could count on you to help me out with this. This is the only medicines that help with my pain.
I'm sorry, but it is clear, I had no idea that this was going on. Had I had any idea, I would not have prescribed the way I've been prescribing. So I'm sorry, I can't treat you anymore. You betrayed my trust. You broke the pain contract. I'm sorry, you're going to have to leave.
Aren't you a person who's supposed to help take care of someone with a medical condition?
I'm going to have to ask you to leave now. Okay, I have my next patient waiting. Thank you.
Okay, so another example of terrible care, right? Hopefully you noted the point of the narcissistic injury. I had no idea that this was happening. My teenage kids have seen this video. Now they walk around my house saying, I had no idea that this was happening. So, but also very sad, the patient saying, aren't you someone who's supposed to help a person with a medical condition? But for more than 200 years, we have not conceptualized addiction as a medical condition. And this may seem extreme, but actually this kind of thing is happening for real all over the country. Patients who for decades were prescribed very high doses who are now being told to go elsewhere. They're being referred to as opioid refugees, wandering from clinic to clinic, trying to get somebody to help them, not even necessarily prescribe opioids, just take care of their pain, help take care of them. So this really begs the question, how can we do better than fluctuating between enabling this problem or retaliating against patients who develop this problem? Where do we go from here? In conclusion, I'm going to go through very quickly what I think are some important policy interventions. There's already been a lot done, but I think we need to continue to emphasize certain aspects of our interventions. And there are also interventions that are not happening that I want to highlight. First of all, how do you intervene with any kind of epidemic, whether it's opioids or tuberculosis or measles? There's primary prevention. You reduce new cases. And in order to do that, we have to reduce new initiates, reduce opioid exposure. That's what the CDC guidelines is all about. Do not give opioids first line for pain. They're dangerous drugs. When you do use them for acute pain, use them in the smallest amount for the shortest duration, right? Tylenol, ibuprofen, they work as well as opioids. If it's really, really severe, like somebody comes into the ED, with their femur sticking out, okay, use opioids. Or someone gets open heart surgery, of course you're going to use opioids perioperatively, trying to minimize them and afterward. But the idea now is to give no more than 3 to 7 days for acute pain and then to transition to non-opioid treatments. Really, really important. Simple, yeah.
In fact, he had 3 little pills.
Yeah.
No use, and I remember perfectly, recently I found them and I flushed them out.
Wow, amazing. I mean, I love that example because you hear open heart surgery and you just think, oh my God, they have to crack the chest. It must be so incredibly painful. It seems like it really warrants at least a month worth of opioids, right? And yet, not true in your son's case. Now, somebody else might have needed those opioids and might have even needed more. So it's not to be judgmental about people's subjective experience of pain because it varies. And not to be withholding when people really need pain. There's a time and a place for opioids. That's not my message here. But my message is we do have this preconceived notion that people need a lot more than they actually do. And a lot of the interesting work that's going on now is actually looking at minor and major surgeries and seeing how much opioids people use and discovering that they're not using nearly the quantity that they're being given in most cases, which is also a problem, right? Because even if they're not using them, it's sitting around in somebody's medicine cabinet for somebody else to be exposed to, which has been part of the problem. Simple policy nudges can make a difference. This is a study that showed that if you just made the default electronic medical record number of pills smaller, like they did instead of giving 30, the default was 10, and lo and behold, doctors prescribed fewer opioids because, you know, the path of least resistance. They just went with the default in the medical record. Gee, if the medical record said 10, then maybe that's what I should be doing is 10. It's also easier. It's one less click for me. And finding that when they, and a lot of studies now showing that for surgeries, for all kinds of pain conditions, giving patients fewer opioids for acute pain leads to patients taking fewer opioids for acute pain without any real decrement in pain relief. So this is really good news. We really can give fewer opioids. We should give fewer opioids. And people are not, on average, having more pain because of that. Alongside this, I think we need to change the perverse incentives inside healthcare that are driving overprescribing, and I talked about those. We need to eliminate patient satisfaction surveys. I believe they're largely orthogonal to good care. We need to reimburse providers for educating and spending time with patients, not just prescribing pills and performing procedures. We also need to make sure that insurance companies will pay for non-opioid, non-medication treatments like physical therapy, acupuncture, psychotherapy, mind-body work, Feldenkrais, trigger point injections, all of these things that we really do know work better for chronic pain in a multimodal way. I believe that we need to create deprescribing clinics. What do I mean by that? I mean that we've sort of focused on people who've become addicted, and that's good, but we've forgotten about a whole bunch of people in the middle who don't meet addiction criteria but are on very high doses of opioids and need help coming down. I think we should institutionally create deprescribing teams or deprescribing clinics to slowly and compassionately take people down. We created a free online CME course here at Stanford teaching doctors how to safely and compassionately taper patients off of opioids. The main message here is it's a lot slower than the prior guidelines recommended. So prior guidelines were like, oh yeah, just decrease by the starting dose 10% per week. No. We are typically decreasing by maybe 10% every month or two in these patients. I have many patients who are on year 2 or 3 of their benzodiazepine/opioid taper. Why? Because of that phenomenon of neuroadaptation. Remember the gremlins? It's a much less injurious insult to the neuroadapted brain if I decrease more slowly, let the gremlins adjust, give the patient time, and then go down. So here are the pearls of a safe and compassionate opioid taper. Go slowly. Enlist the patient in the process. Start wherever they're willing to start. If they want to start by reducing their fentanyl patch, do that. If they want to start by reducing their hydrocodone and keeping their fentanyl patch, do that. Let them drive within reason. Patients can tolerate a lot more pain, and people can tolerate pain when they're somewhat in control of administering that pain. So, if they say, I think I can go down by this much, great, go down by that much as long as you're making forward progress. It's okay to take breaks. The important thing is not to go backwards, because if you go backwards, you lose all of that gain you made when you went down, right? The gremlins hop on again and you're sort of starting over. So I say to patients, let's wait until you're really able to commit to this lower dose, and then we're going to commit, right? We're not going to go down and go up again. Okay, so this is not rocket science, but in order to have a successful takeoff, you have to prepare people for the journey. So here's what you have to tell people. Opioid withdrawal is painful, especially if you're a chronic pain patient, because opioid withdrawal involves body pain, even if you're not a chronic pain patient. So if you already have pain, when you go down on your opioids, you're going to have more pain. Nausea, vomiting, diarrhea, these are all the symptoms of acute opioid withdrawal. But the universal symptoms of withdrawal from any addictive substance are irritability, anxiety, insomnia, and dysphoria. You got to tell your patients this. Not only will you have nausea, vomiting, diarrhea, and all that fluids of opioid withdrawal, but you're going to be more anxious. You're going to be more irritable. You may even feel temporarily depressed and suicidal. You are very likely to have more body pain, okay? Bottom line, it's opioid withdrawal mediated. This is not a progression of your underlying pain disorder. This is not the pain that you will have to live with. This is opioid withdrawal mediated, and tincture of time alone is the treatment for this. So if you can just stick it out for 2 to 4 weeks, I promise you, your body will adjust to the lower dose, and you will feel pretty much the way that you felt on the higher dose, but now you'll be on a lower dose. I often use a cancer treatment metaphor. I say to my patients, I'm asking you to do something really hard. The idea, it's kind of like chemotherapy for cancer. It's a really hard and painful treatment, but when you get to the other side, you'll be better off because you'll be on a lower, safer dose. And believe it or not, your pain may even be better because of this opioid-induced hyperalgesia phenomenon. And I find I have to go through this list with patients every time I go down on the dose. It's like there's amnesia from the last time. But once we do it enough times, patients will say to me, you know, Dr. Lembke, the most important thing you told me in this process of going down was you told me that it would hurt more, but if I just waited that it would get better as my body adjusted. That was so helpful to me because when I feel pain, it's terrifying. It's so scary. It's so awful. But I just thought I just need to wait and it'll get better, and it did. So what you told me it would happen did happen. Let me tell you how this is different from what a lot of doctors do, which doesn't work, is they minimize the process. They say, oh, you're going down by 5 milligrams. That's nothing. This is going to be easy, no problem. And the patient goes home and it's not no problem. It's incredibly excruciatingly painful for them. And then they're terrified because it's like, wait, he said it would be no problem, but it's really hard. So what I tend to do is to go to the other side and I say, this is going to be super hard. I'm asking you to do something really hard. And then when it's not that hard, it's like bonus. What else do we need to do? We need to think of addiction as a chronic, relapsing, and remitting disease. And I ask you to do that even if you don't believe it is one. If we don't conceptualize addiction as a disease in this day and age, we will simply perpetuate the problem. If we're really going to conceptualize addiction as a disease, we have to build an infrastructure inside the House of Medicine to treat addiction, which we do not currently have that, right? We do not have that. People have to go pay a lot of money to go to Betty Ford, or they have to go, across the tracks to go to their methadone maintenance clinic, which is not even in a medical building. It's like in a house. We don't have systematic, comprehensive, insurance-covered resources for people with the disease of addiction, and that's a shame. We made progress with the Mental Health Parity and Addiction Equity Act of 2008. This was codified into law with Obamacare. Basically just said, hey, you have to reimburse doctors on par, doctors who treat mental health and addiction conditions on par with other medical conditions. It's a real medical condition. This really was a game changer in terms of people being able to get treatment, but we're still not where we need to be. There are still all kinds of loopholes and runarounds. When I want to prescribe buprenorphine, for example, I have to fill out a prior authorization form. Do I have to do that when I prescribe OxyContin? No, I don't. Which one's more addictive? Definitely OxyContin. But I have to jump through all kinds of hoops for buprenorphine. Buprenorphine is an opioid. It treats opioid addiction. It has unique properties as an opioid that make it well suited to treat opioid addiction. Is it abusable? Sure it is. But it's a harm reduction strategy. People are less likely to overdose. It doesn't have the same respiratory suppression. It has a really long half-life, so it gets people out of this cycle of intoxication and withdrawal that they get with shorter acting opioids, which is so debilitating. And it has a very tight binding affinity in the mu-opioid receptor, which means when buprenorphine is in there, other opioids like heroin and Vicodin and OxyContin cannot get in. So it has kind of this, kind of a blocker property, but it's an agonist. We just started an inpatient addiction consult service. So for hundreds of years, we've had patients come into our hospitals with terrible medical consequences of addiction. Valve infection because of intravenous drug use, liver disease, traumatic injury. What do? We patch them up and we send them on their way. And we never address the underlying cause of the medical problem, the addiction itself. But it's a wonderful opportunity to do that. We've started an addiction consult service here in the hospital. They've been started at other institutions around the country. When a patient comes in with a medical complication due to addiction, we now are urging the hospital to consult the addiction medicine consult service and have our people come around and say, hey, we can offer you this treatment. Hey, would you like to see this person afterwards? Hey, we have a medication for alcohol use disorder. It works pretty well. Do you want to try it? We do not have the workforce that we need to combat addiction. Doctors don't want to go into it. It's not sexy. It doesn't pay well. So I was part of a movement to implement something called the Substance Use Disorder Workforce Loan Repayment Act, which was taken up by Representatives Clark and Hal Roger and is now law on the Support Act. Basically, it says that if you spend an additional year doing an addiction medicine fellowship, which we have here, and then spending time in a community that's been afflicted, treating addiction, we will reimburse your medical school loan. How awesome is that? Peace Corps for addiction, but it's also not enough. You know, until there's real parity and we actually incentivize doctors by paying them to do this work, we're not going to get enough people in the field. Another exciting movement is peer recovery counselors. This has been a long tradition. People in recovery from addiction themselves, helping other people with addiction. We're now hiring people as peer recovery counselors to work as part of the medical team in the hospital. Very exciting. We just got a grant recently to do that, and we're going to hire a peer recovery counselor to work on this addiction medicine consult service and maybe lead some outpatient groups. I believe we need to reform disability, which I alluded to. What do I mean by that? I mean, if we're going to say that medicine is our social safety net, then we have to give doctors the resources to treat the problems that patients really have so they don't biomedicalize non-medical problems, or we have to build a social safety net outside of medicine. Also, we need to limit the influence of special interest groups like the pharmaceutical and medical device industry. This is a huge problem, nearly feeling at times insurmountable problem, but we've got to find ways to make our practice of medicine truly evidence-based and not based on the bottom line of a company. And of course, we need to provide alternative sources of dopamine. Freud said love, work, and play. Many people in this country have none of those things and turn to drugs as a result. I'm going to leave you with this quote by Reinhold Niebuhr. He's a 20th century philosopher. Ultimately, evil is done not so much by evil people, but by good people who do not know themselves and who do not probe deeply. Here's my book if you're interested. These videos are available free online. Thank you so much for coming and for listening, and I'd be happy to take any final questions that you have. Yes?
So I'm not sure there's an easy answer to this, but you had mentioned getting alternative treatments, whether it's like physical therapy. So what are the barriers? I imagine it's more than one answer to that.
So the hugest barrier is reimbursement barrier, which is again and again, you know, the barrier here. If you don't pay providers, if they can't make a living wage, and then they're not going to offer those services and patients aren't going to get those services. The one exception will be if you're in a wealthy community like ours, then you're going to have, you know, executive coaches and you're going to have physical therapists and you're going to have all kinds of people sort of running a cash business, and lots of people who can afford that will consume that better health care. Very difficult to get reimbursed. A lot of medical justification forms required. A lot of fail first criteria, meaning they have to fail this first before we'll authorize that. Then it's limited. I mean, you know, we overconsume all types of health care. So we have to ration health care. I'm a big believer in that. The problem is we're not rationing the health care that is not that healthful, and we're not paying and providing the health care that really would make a difference.
Is the medication or the physical therapy, if you will, is there a similar in cost? Does it cost the same to you know, for insurance to pay for a prescription, or versus some other type of intervention?
Well, it's a really interesting question. So a 10-minute cataract surgery earns 4 times as much as a 50-minute psychotherapy session. Now, so then you can ask yourself, well, what costs more? Okay, what do you need for a psychotherapy session? You need an office, you need a couple of chairs, maybe there's a little bit of overhead, right? So the cost is low in that regard, but the labor is there. That's a human interaction. What do you need for cataract surgery? Well, you need an operating room, you need a lot of devices, you need assistants and nurses. So there's a lot of overhead there. But the difference between, what those actually cost and so what you need to charge the patient or charge the insurance company is not equal to the actual cost. Because what you have piggybacking on the cataract surgery is a whole lot of companies behind that who are making a whole lot of money by supporting, enforcing their lobbyists. So it's like a whole business, that's driving performing procedures and prescribing pills. Everybody's a big gravy train of people making money. Whereas psychotherapy or physical therapy or, there's not a whole machine behind it, and so that's why you get the discrepancy. And it has almost nothing to do with the value, right? I mean, I think cataract surgery is really valuable. When I get my cataracts, I'm going to want to get cataract surgery. But I think psychotherapy can be valuable too. And so, but we just don't, it's not a rational approach to the, time and labor spent. It's not, I think that it's not right and it's not fair for an ophthalmologist to make 10 times, in 10 minutes what a psychotherapist makes in 50 minutes. But as long as there's that discrepancy, you're going to have all these young, bright Stanford medical students, they're going to go into ophthalmology. They're not going to go into addiction treatment. Yes?
Why do you think this culture of like overprescription and this like whole business model has been so popular in the U.S. and not in others?
Well, part of it is our healthcare system. So we have a fee-for-service healthcare system, and a lot of other countries have a national healthcare system that is based on a different model. So I think it's partially the healthcare conglomerate that's driving it. We basically, if patients stay sick, we make more money. There's an attempt to stem that tide with value-based care and bundled payments, but I'm not sure it's really working. Kaiser has a very good model because basically they have, lifetime subscribers. They practice what's called population health, and their bottom line does better when their patients consume less health care, right? And so ultimately, so Stanford is kind of moving toward that Kaiser model with SHC. People are beginning to catch on. But basically, I think it's this entrepreneurial, capitalist, fee-for-service medical system that's essentially driving this. One thing that's interesting, though, is that places like Canada and now Europe, Canada has not been immune to the opioid epidemic, and they have a national health service. Europe, they have national health service, and they have growing rates of opioid consumption, which is very interesting. So part of it is cultural, also, just people just kind of wanting a pill for every ill and wanting it to be fixed and wanting it to be fixed quickly. And the fact is that these medications do work really well short term, but long term they stop working and they cause all kinds of problems. But we're not a culture that's set up for the long view. Yes?
You mentioned mind-body work, so I was curious how much that is being used with chronic pain.
So prior to 1980, that was part of the standard of care for chronic pain. There was real recognition that it was multimodal interventions with a lot of mind-body work was the best treatment for chronic pain. Then there was this paradigm shift, opioids, and now we're swinging back to that. But access to that care is really tough. Insurance companies won't pay for it. In a lot of rural settings, there aren't people doing Feldenkrais, But we do know, first of all, I think it's important to establish that we don't have good treatment for chronic pain, and that a lot of people struggle with terrible chronic pain conditions. Excruciating, unbelievable pain that we really don't have good treatment for. So part of it is acknowledging that and then trying to help people live as best they can with pain. And that means modulating those other areas, frontal lobe and limbic function, your gray matter and your emotion brain, to help you manage the anxiety and the despair that come with experiencing pain. Because that kind of pain is probably not going to go away. And so it's learning, how to basically train your brain to tolerate it. And we do know that anxiety and depression amplifies physical pain. So when we can manage the anxiety and depression, the physical pain actually does tend to go down, even if it doesn't go away. Did you have a question? Yeah.
So I keep hearing very sad stories about drug addicts being thrown in jail for some infraction and then there being no treatment in the jail. Is that changing? It seems like that would be a place to start instead of just throwing them back in the street with the first thing they do is go find therapy.
Yeah. So let me qualify that a little bit. For decades, the jail system has actually been one of the primary places that people with addiction get into recovery. So it's been actually an amazing resource, especially people who get into recovery through faith-based practices, spiritual transformations, 12-step recovery. A lot of people, that's where they get their place. There was an interesting look at a study by John Kelly at Harvard at Alcoholics Anonymous, and seeing how people get funneled into Alcoholics Anonymous, Narcotics Anonymous, and other 12-step groups, which is a secular, spiritual group to help people with addiction. And about 25 to 50% of people actively in Alcoholics and Narcotics Anonymous got there through the jail system. So that's one piece of that. But you're absolutely right. One of the things the jail system has consistently not done is provided especially opioid agonist therapy in the form of methadone and buprenorphine in the jail system. So you have people who are addicted to opioids who go into jail because of some usually drug-related infraction, go into severe painful withdrawal in the jail system, are off of opioids in jail, get released, go out and score their usual amount and die because now they've lost their opioid tolerance. So a huge spike in overdose deaths with people being released from jail because of that. But also just the sense that, hey, if opioid addiction is a medical disease and opioid agonist therapy in the form of Suboxone or buprenorphine and methadone is evidence-based treatment, which it is, multiple placebo-controlled trials across centuries and continents shows that it helps people with addiction, helps decrease transmission of HIV and hepatitis C, helps people decrease their involvement in crime and live more meaningful lives, then it should be offered in jail. The good news is we are seeing progress in this area. Rhode Island, for example, is a state, it's a small state, but they've made amazing strides in this regard. They now offer opioid agonist treatment and naltrexone, an opioid blocker, to treat opioid addiction in their jails and prisons. And we're seeing movement here in California in that regard as well. But there's still enormous resistance, especially in the southern United States, southeastern, to provide this kind of treatment in the jail system. So we have patients, for example, who are doing well on buprenorphine, have to go to jail for some other reason, and then have to go off their buprenorphine when they go to jail. It's kind of awful. Yes?
So regarding the paper that recently came out about ketamine being involved with the opioid pathway that came out from Stanford, I just wanted to know your opinion or any insight into those results, and then also the potential use of opioids or more use of opioids in psychiatry based off of these results.
Yeah, so opioids have been, you mean for other indications? Yeah, so, well, first of all, so ketamine, it's an NMDA receptor antagonist. It's a dissociative anesthetic. It's addictive. People abuse it. They get it online in the dark web. They get it from veterinary clinics. People describe going into a K-hole. It's been used a lot as an alternative to opioids when people need analgesia for pain because it's very effective. But my worry is, it's always like we go from one drug to the other, right? So now, okay, well, we're not going to use opioids, but ketamine, and it's safe and it's effective. What the paper that you're referring to showed, this is by Nolan Williams now and Schatzberg and others, that basically ketamine mediates its effects partially through the opioid system. So it's kind of an opioid. That's not at all a huge surprise to those of us in the addiction world who have seen our patients misuse and get addicted to ketamine. We published a case report of a patient of ours who went to the ED, had an acute injury, said, I'm an opioid addicted person on buprenorphine, I can't get opioids. They gave him ketamine, he absolutely loved it. He went out, got ketamine on the dark web, injected himself multiple times a day for 2 weeks, ended up in the ICU and almost died. So this is not a benign drug. It's a little bit like marijuana, similar category. Everyone's saying, okay, well, let's get people on marijuana to help manage their chronic pain. Marijuana works really well for pain short term. Over the long term, there's not good evidence that it works. So again, you've got this chronic pain, probably because neuroadaptation. The advantage that marijuana has over opioids is it's really hard to overdose on marijuana. You could consume very large quantities for a really long time and not have like a lethal overdose. But it's not a benign drug. It is addictive. It is associated with adverse medical and psychiatric consequences. But it's always, again, it's not in our culture to be able to want to like give up anything and sort of live with pain. We're always looking for a way to eliminate pain. I'm not a fan of the use of opioids in treating any psychiatric condition except for opioid addiction, which to me is unavoidable because you've permanently changed the brain as a result of opioid exposure. So that's why it's a viable treatment. But I wouldn't put anybody on chronic opioid therapy for anything for all the reasons that I've talked about, although I know it's been explored as a treatment for depression and a treatment for OCD and all these things. I don't recommend it. Yeah. Thank you so much for all of your time and attention today.
Well, thank Thank you, everybody. We thank Dr. Lembke for this wonderful presentation and informative, and we really enjoyed it. Please make sure you sign in. There is a sign-up sheet up there, so make sure you've signed in. And we will also send you the evaluation. So we would appreciate if